So while the surgeons and radiation people were refusing to de-escalate, I've agreed to. Okay, so that tells you that I'm much more broad-minded than all of them. Or rather, we as a group, medical oncologists as a group, are happy to de-escalate faster. So that is all of us downloaded versus read, and after reading, that's what all of us end up being, right? You're just kind of confused, you just don't know. Already people sitting in the front have told me we can't do anything much beyond remembering the names. Even that's becoming difficult, so let's try and see how in the next, 40 minutes, not too bad. Lovely. So we'll start with the patient case and then try to fit in each of these abstracts that we have to see how it will help us manage these patients. So here is a lady who's 38 years old, who's BRCA2 positive. She's had a mastectomy and sentinel lymph node for her left breast cancer. There was no prophylactic mastectomy or salpingo-oophorectomy done. 5-centimeter tumor, grade 3, lymphovascular invasion present, no perineural invasion, 70% ER, 40% PR, HER2 negative, Ki67 is high. So it's a PT2N0. She did have an oncotype DX done, and the risk score is 32. Certainly, we'll all do chemo, no question about that. So this lady had dose-dense epirubicin cyclophosphamide followed by paclitaxel, so that was done. So let us start with the other questions. Let's start with Hitesh. Hitesh, ovarian function suppression or not? So we're going to have a rapid-fire panel discussion because my time has been. All the surgeons are immediately saying yes. Okay, right. You want to go back? Sure, Dr. Rugo. So T2N0, grade 3, high Ki67 oncotype was done. Yes. So chemo also done. So Hitesh.
Yeah. So OFS?
Yes or no?
No.
Okay. Anybody says yes? 38. Okay. Surgeons. So keep a watch on this front row. Okay. So they're prompting you. Anybody else? Anybody says yes?
Yes.
Okay.
I'll give.
Yes.
Oh, yes. Okay, the answer is done. So let me ask Dr. Rona, how do you choose whether you want to do OFS for a particular lady with leukoregional or operable breast cancer?
So, OFS is...
What are the factors that you consider?
Of
Because
course,
I think,
the age.
so just to, expand that a little bit, I think the reason why he said no was this was node negative. Probably that's the reason. Yes, he's nodding his head. So I want you to just quickly expand. What are the factors that you will take into
Age is
consideration?
essentially a big factor. It's a 30-year-old lady.
38, okay.
38, yeah. Yes, and OFS definitely shows benefit in hormone-positive breast cancer.
So are nodes the only, so the question is, are some factors very overarching versus some other factors which, radiation oncologists will call as soft indications?
Of course, node positivity is high grade, node positivity, that are the important indicators for OFS, but young patient also it is better to
Just
consider.
being young tells us that this patient should go in for ovarian function suppression. Dr. Rugo, you wanted to?
So, there was an interesting analysis on some of the earlier endocrine therapy trials looking at women who were younger than the age of 40, and even patients who had luminal histology had a worse outcome than older women. And I think that that's largely due, indeed, this luminal doesn't tell us everything, right? So these cancers behave more poorly. Even when you give chemotherapy, a high recurrence score correlates with a worse outcome in terms of invasive disease-free survival. And we know that in patients who have high-risk disease, that ovarian function suppression helps more depending on how much your ovaries are functional, right? So if you're under the age of 40, you're going to have a lot more ovarian function. Now, for this woman, I would suppress the ovaries even if she was older, in her 40s, because I really believe that that makes a big difference. And I think that we have data in the metastatic and now adjuvant setting, as nicely presented earlier. So I think that that's an important part of her treatment. We also, of course, are learning more about other treatments, which I think you'll ask us about as well.
Which
but
we will, yes,
I think in this situation, you have bad biology in a young woman with high production of estrogen.
Excellent. Dr. Bhavna, 2 or 3 years versus 5 years, that's the next question. What would you do?
I would like to stick to about, say, 2 to 3 years.
2 to 3 years, any specific reason? You're not convinced with the 5-year evidence or?
We also need to consider the toxicities of ovarian suppression
Excellent.
at the same
Yes.
time.
Yes.
So we have adequate benefit. She's also received other medications, dose-dense chemotherapy. So we are trying to add benefit of each and every parameter, each and every treatment that we are doing.
Okay.
So I would consider that factor
Excellent.
also.
Dr. Anita, if somebody is tolerating ovarian function suppression well and that lady is happy to continue till 5 years, would you say 5 years is okay? Is that good?
No, tamoxifen I'll continue.
We'll
with
get to tamoxifen next.
But
We're
not
just
the-
talking about the duration of OFS.
OFS 2 years.
2 years. How many in the panel will say 2 to 3 years? 5 years? 5. Okay, so let's say that we'll do at least 2 to 3 years, and if somebody is tolerating it well, it's good to go to 5 years. We did see the results of the Astra study. Next question is tamoxifen versus AI. Biswajit?
Can I just ask?
Yes, please.
The duration of ovarian
Yes,
suppression.
yes.
So I think 5 years, many people would accept. I have a dilemma when I have a woman who's 33 years old, was really high risk, and now she's gotten to the 5-year time point.
Okay.
Now the question is that would you withdraw ovarian suppression at that point of time, and off the record have possibly continued it for some more time, but maybe, thoughts of the panel on that.
Just like whether the earlier dilemma with the AI was. Dr. Rugo, quick answer to that question? Would you continue? Would you stop?
Yeah, I have also continued. I mean, I think this patient is a large T2 and node negative. So that's a biology that's a little different than a patient who has 4 or 7 nodes. But I just saw a woman who's, now 8, 9 years out and still on ovarian function suppression. And again, she was diagnosed at 30 and had surgery with recurrence in breast 3 weeks later. These are very high-risk patients, but she's an ED. So I think in that situation, we do tend to extend out a little bit longer. But in this patient, maybe you could, if you wanted to continue endocrine therapy, you might think of switching to tamoxifen, depending on how she's feeling.
Excellent. Lovely. So at least 2 to 3 years, 5 years if possible, extend it if need be.
Let me just ask, what's the data for stopping the OFS at 2 to 3 years?
What's the data? Okay, let's say Astra or some of
Well,
these studies
Astra,
in
but-
which we initially did ovarian function suppression, which was randomized to chemo, and that's the
it's
evidence
not
for
asking
doing
the
it.
question. I mean, the only data we have says that if you gave, tamoxifen for 2 years versus 5 was better even out to 15 years.
Correct.
So
Agreed.
I don't, and then we have the Austrian breast and colorectal study group trial where they gave 3 years, but those patients generally had lower risk disease. So I guess for me, I would feel like I was sort of pulling it out of a hat to say I'm going to stop at 2 to 3 years. Toxicity is an incredibly important point.
Yes.
If somebody doesn't tolerate it and won't take it, there you are.
That's
But,
right.
you just have to manage.
So I still stick to what I said, that if toxicity is an issue, stop there. If you can continue 5 years. If you think that lady needs beyond that and is still tolerating and is okay to continue, it's okay to continue. AI versus tamoxifen, Biswajit.
Yeah, I would give tamoxifen because the benefit with
Yeah,
AI
she's
is...
BRCA positive. So we are not discussing about the BRCA at the moment. That's probably for the afternoon, I suppose. Yeah.
I would generally do AI with
You
the
would
OFS
do an AI?
because the
Okay.
advantage is not much.
Advantage of what?
Of the DFS benefit with recurrence rate is 1.5 to 2%.
So I think with the longer follow-up of the combined analysis, we are seeing better benefits. And earlier, there used to be an apprehension that the DFS is better, but the overall survival is actually the other way around. So is there a detriment to use of heximestin? But with the 12-year, 13-year follow-up now that we have, there seems to be a 2% improvement in the overall survival, no statistically significant, but clinically significant. So OFS plus AI, again, wherever it is feasible. So I just put this up to also impress upon the point that what we should be looking at is not isolated factors, but look at a composite risk. Because you may have one very important high-risk factor, or you might have multiple small, the soft risk factors. So if you put all of these together, then you end up having a patient who ends up being in the high-risk category. So these are some analysis. These are some nomograms that are available. You can just fill in all these values and it'll give you what's the outcome. So if people like to use it, you can use it. Okay, so that's the analysis. So this is the CDK4/6 story. Okay, so I don't have to tell you what there is. So Novartis, which was looking the way it is there on the screen, finally had success. Okay, so we had the final IDFS. Okay, the final IDFS in 33 months, which is not something that you would expect in a hormone positive subpopulation of patients, but this was an event-driven study, so they said, okay, 500 events for your final IDFS. They had 509 events, so they said, okay, that's where it is. Let me ask Bhavna again. Do you think that this is ready for prime time day after tomorrow morning?
So we are all convinced that all these CDK4/6 inhibitors are different.
So for this lady, so we are coming back to our patient, okay? T2N0 high risk. OFS done, exemestane given.
Okay, fine. So I think if we all agree that this lady has high risk disease, we all have agreed
Yes.
that this lady has high risk disease. So in that situation, it may be worthwhile.
Okay, so you're okay with this 3.1%, the 36-month follow-up. That's 1 in 30 who's likely to benefit. Of course, you're right, because this is the trial that had no negative patients. It was about 15 or 16%.
Yes.
But if at all you decided to do, then this is what you should be doing. So you're saying you will consider doing it. Anybody in the panel has a difference of opinion saying this is too early. And the reason why I'm saying this is this. I've tried to construct this table. The color boxes that you're seeing are the latest results, updated SABCS. The rest of the table is from ESMO. So it's about 2 month difference, but in terms of the data cutoff, it's a little different, 6 months difference. I have, colored green the absolute percentages that went up in the next analysis. I've colored orange or red the absolute percentages which went down in the successive analysis. And for me, it's a little worrisome that with slightly longer follow-up in some subgroups, you're actually not getting the expected benefits as time go by. Dr. Rugo, I want you to answer that question. Is this a concern, especially in the groups that we are interested in, which is N1 and N0? Because that's where you want to watch Natalie and then use it later. For me, I would wait. Your thoughts on that?
Yeah, I agree with you that the data is early. I'm not worried by the lack of improvement. They had 5 more months in follow-up.
Okay,
this was
I
just
agree.
protocol mandated, and it's the final by statistics in the protocol analysis, but by no means the final. And if you look at Monarch E, the difference is increasing over time, and there was a big increase from the 2, 3 to 4 year and now 5 year results, which were just published actually a couple of days ago. So I think that we're just early and we don't know yet. For the no negative group, this is a really small number of patients.
Yes.
And so I feel like, we're not ready to use the drug as a standard of care. The confidence intervals are huge there, 0.3 to 1.17. So, if you separate out the patients who had high risk, very high risk disease, so stage 3, many positive nodes, the difference is much greater in that
4.5%.
population, as you would expect. The other thing I think that's really important is something like almost 40% of patients didn't finish 3 years. So
20% yet to finish.
there's 20-something percent of patients who are still on therapy, but a lot of patients didn't finish 3 years. So I think the big question for us also is going to be the optimal duration, because it's hard for people to stay on those drugs for 3 years. They're fatigued, they have an occasional aphthous mouth sores, they have to check their labs, and it's very expensive, which is a big issue. So I think that plays a role. There's a study which is opening now called the WIDER trial. I don't know if it will be open in India. Yes. So, and that one, we actually pulled back a little on giving it to everybody like water, which was the original design of the study. And it's a little bit better now, but it will provide access for patients who have high-risk node-negative disease, which, I think is useful. It's not a randomized trial, so the information that we get out of it is going to be limited by that, but they'll check blood and, look at a variety of different factors to try and better understand efficacy in that population. Plus, it allows patients to go on who are farther out from their diagnosis. We know they still have risk, so that's useful too. But outside of the trial?
Okay. So for now, I think do all of us agree that the follow-up is a little short? And then we wait a little longer. But for me, the interest area is N0, and that's always going to be a query. This trial is really not going to answer that question. And that brings us to the next question. So Avinash and Suhas, Natalie or Monarch? Let's say you get a patient which is really high risk, 4 lymph nodes, what would you want to do?
I would like to go with abemaciclib, sir.
You would like to go with abemaciclib. The reason for that is what we already discussed, or is it something else?
No, we have the longer follow-up data is there, and the difference is growing. So why not?
Very good. So the difference is going. We've got longer follow-up data, so we are happy to follow abemaciclib at this point in time rather than shift to ribociclib. So does everybody agree with that? Lovely. Suppose the patient does not tolerate Avinash.
No, I don't know. Like
Give them placebo.
switching to ribociclib.
Switching to ribociclib
theoretically
is an
is
option. Yes, if you really think that this patient belongs to a high-risk category and for some reason is not able to tolerate abema, even after dropping down the doses based on what you would routinely do, then it's okay to shift, I suppose. But all points well taken. The longer the duration, more expensive, less compliant, all these issues will come up when you put somebody on, but it's there.
So,
It's
Doctor,
there.
can I make a
Yes,
comment?
please, Dr. Paul.
So, also it is interesting to see that the dose of ribociclib
It's 400
which is
milligrams.
400 for adjuvant and for metastatic cases, we start with 600. Some patients may still require. So, that is also a difference. So, whether if even 400 is enough. So, that is another question which comes to our
yes,
mind.
In the metastatic trials,
Yes.
60% of patients dose reduced to 400, and the outcome in that 60% is identical to the
Yes.
other patients. So, it may be sort of a in vivo pharmacogenomic test. You don't tolerate the higher dose, but in general, patients tolerate 400 better. And, there's an additional toxicity from CDK4/6 inhibitors we track poorly, which is fatigue. And in our early stage patients, in some ways, it's a much bigger issue. They're trying hard to recover. They all got chemo. So I think 400 was a really clever dosing to use in the adjuvant setting, because I think 600 would have been a mess.
And also there's some small randomized phase 2 data to say that 400 and 600 are equivalent in terms of PFS. Response for 400 seems to be slightly lesser compared to the 600, but the PFS is the same and the toxicities are lesser. So I think, as was rightly pointed out by Dr. Rugo, it was very wise and clever to take 400 as the dose rather than 600. Quick question, olaparib or not, node negative? Dr. Anita? We are on a rapid fire, so I'm going to...
I'm not sure.
Node
You said
negative, so no olaparib.
No.
So you would?
Well, no, so this
Okay, so you're looking at the risk rather than the anatomy.
This patient I would treat in the neoadjuvant setting if I could.
If it was,
So-
even if it's strongly ER positive, you would
Oh
still.
yeah, she has a higher, if I'm going to give chemo, I'd rather give it in the neoadjuvant setting, and
Okay,
then she
that's
has
a
residual
nice point.
disease, I give her olaparib. And so I have a really low threshold for using olaparib in
Oh,
these
is it?
patients.
Okay.
Yeah,
So, please
we
go.
have great data on I-SPY too. So we use MammaPrint just because that's, Laura Vantvere was one of the people who helped us start the trial and is at UCSF. But and MammaPrint gives us blueprints so we can get the intrinsic subtyping. But if you have a high-risk genomic score and you're going to give chemo, some of those patients, they're luminal B, right? The PCR rate is 15% up to 25%, depending on the intrinsic subtype. So in that situation, I would give neoadjuvant therapy. And we look at these, we give neoadjuvant endocrine therapy. We have a bunch of studies, though, through I-SPY. And then it helps you with the post-neoadjuvant therapy.
Okay.
So again, I would treat her in
So-
the neoadjuvant setting. And if she had residual disease, I would give her
Yes.
olaparib.
So that's how you would use olaparib.
And then
if
the
you use
one question
neoadjuvant
is,
therapy.
so I'll ask,
So CDK4/6 would also be there, so you sequence it then because olaparib and CDK4/6
So what
cannot be
sequencing
given
are you
together.
gonna
So
use?
we would generally do olaparib first for the first year, and then after that do the CDK4/6. That's how we would do if you ended up having both. Okay, so the point is that if somebody's got luminal B disease, somebody's got all the high risk factors, somebody is young, then there's a tendency to do neoadjuvant rather than adjuvant. Even though if somebody can still be operated upfront. It's not absolutely wrong to do that, but I think the trend is that we're moving neoadjuvant, so that's what it is. Okay, so let's summarize that part. We are exactly halfway and we've done the early breast cancer. So we look at composite risk rather than looking at one factor. High risk chemo is definitely going to be there. Ovarian function suppression, 3 years at least, 5 years if possible. Beyond that, if necessary, depending upon tolerance. AI wherever possible compared to tamoxifen because that gives better results, especially with the combined analysis long term. We would do a CDK4/6. The node-negative group in the NATALY seems to be very small, and the follow-up for NATALY on the whole seems to be very short, so it's too early to adopt that in day-to-day practice. We would stick to abemaciclib for that high-risk group as of now. Typically, in this patient, we would not put her on olaparib based on the trial criteria, but there may be situations you would use it in case you did neoadjuvant chemotherapy for this patient. We would not have had the risk score at the time of diagnosis, especially the way we do breast cancer practice in this country. So we will move on.
Sir, one question
One
from
quick
my
question.
side about the chemotherapy protocol. In this patient, obviously, we can...
Not for today,
Okay.
some other day. Right, okay. Okay, so there we are, Sonia. Okay, Sonia means wisdom, right? So is Sonia a little too late to the party? Yes, everybody is nodding vigorously. As they say, Sonia got divorced even before she got married, is what they said. Okay, so is this, okay, let's assume that, okay, this is still relevant to a certain extent in the Indian context because there are patients who can't afford that 5,000 rupees of palbociclib also, so we can't, completely discard the results here. So let's say Biswajit, since you work in a large community hospital and academic center, suppose you were called to, comment on whether palbociclib should be given in Ayushman Bharat or not. What would you do? Would you say use it first line because of all those benefits, or you say it's okay to use it later because you would not compromise the outcome, at least based on this study, and you would save a lot of money? What would you do?
This question becomes irrelevant because of the generic availability.
No, I'm
The
saying
generic
even
was not
5,000
available
rupees
then
for
it
a
was-
country as big as ours, with the kind of number of breast cancer patients that we have, is still big. What would you say? Because
I would still recommend giving
you
it.
would still recommend giving it in the first line?
First line.
Lovely. So next time anybody Ayushman Bharat, call Biswajit, right? He's going to give you the right one. The other thing that I wanted to ask, and Dr. Rona, you can take that, is this trial a palbo-specific trial? Because we know that Ribo has given us overall survival benefit in 3 consecutive studies, the Mona Lisa 7, the first-line cohort in 3, and Mona Lisa 2. So conceptually, it makes a lot of sense to delay it, but 3 consecutive studies giving you overall survival benefit, are you a little hesitant to say this is the way to go?
No. Even though that second line setting also showed benefit, first line setting is the ideal place to place CDK inhibitor.
Okay, so Sonia remains late to the party, so we will move on. Any point in doing biomarker analysis to choose patients for CDK4/6 inhibitors? No, Dr. Rugo has already nodded, so we will move on. That will save some time. Okay, so the next question is, do all of us agree that the first line treatment should be an AI plus a CDK4/6 inhibitor? Yes, all of us are. But Dr. Rugo, I want you to answer this question for me. The PFS in Parsifal is simply much, much higher than what you get in all the Mona Lisas and the Monarchs and the, the Palomas, both in terms of the PFS and in terms of overall survival for palbociclib, should I say. Because palbociclib, even if you look at what's happened in the Sonia, it gave you an overall survival of 45 months. And here you're seeing 63, 68, some phenomenal numbers. So you think, is there any way to explain this? Because the PFS that you would get with the first line CDK4/6 is about 24, 26 months. Here you're seeing some 34 months. Overall survival, very high. Any thoughts?
I think that the PFS doesn't surprise me so much because I think it's within the range of what you might see with, error in different populations.
Okay.
The overall survival was really interesting because I think there were a lot of problems with Paloma 2 and the population, as well as the follow-up even for survival. But, survival is a pretty hard endpoint. I thought this was impressive. I think that the survival here is quite similar to what it is in all of the other first-line trials. And the hazard ratios, in those trials, if you look at the patients who had a longer disease-free interval in Paloma 2 are similar, you just can't. I think what it tells us is that there's a lot of heterogeneity in clinical trials, and cross-trial comparisons are complicated. I mean, we have the early stage problem with palbociclib also, and there may be differences in potency of these CDK4/6 inhibitors, but this was at least encouraging for patients who need to be on palbociclib for whatever reason it is. We tend to choose the other first, but there are patients who can't tolerate anything but palbo, and it's cheaper. So I think that those are important considerations.
Point well taken. So
there is a really
sorry,
interesting,
yeah.
The Inavo 120 data that was this
Yeah,
really late-breaking data.
We will come to that at the
It's
end.
unbelievable.
Yes.
But it does bring up the question of, what you do for people who have that endocrine resistance phenotype.
Yes, you're going to have the last word on that because I have a slide on that because that's not part of the list that was given to me. Right, anyway, never mind. So the point is that especially if you're using palbociclib, it's perfectly all right to use because you've got some good data here to say that it's not bad at all. And as was rightly pointed out, it's very difficult to cross-compare studies, the heterogeneity in the population, the markers that they may or may not have, and so on and so forth. So this is reassuring for me, especially because the majority of our patients still go on palbociclib. I'm going to show you many other studies where palbociclib actually failed, and somebody in our tumor board asked once, is it palbociclib or is it placebo-cyclib? I thought that was interesting. Nice, huh? It was a surgeon. Okay? And you know that. And you know who the surgeon is. Lovely. Okay, so oral SERDs. Now we are getting into an area which, we don't have access to, but it's okay. It really enhances our knowledge about the way this field is moving. So I think it's worthwhile discussing all of these. So let's assume for a moment that we have the oral SERDs, we have capivasertib and all of these, and we have the ability to do our NGS in the best of labs with good quality. And because that's going to be a companion when you're going to make your decisions on all of these medicines. So let us start again with the oral SERDs for whom?
Oral SERDs for ESR1 mutant patients.
Okay.
And as of now, elacestrant, if
elacestrant,
patient
if it
has
is
not
available.
received fulvestrant previously, then definitely elacestrant.
Okay,
This is what
excellent.
I would prefer.
Okay, so when would you do that ESR1 mutation? Would you rebiopsy or would you do it in the blood?
Liquid biopsy is good. Validated liquid biopsy is good enough.
Very good. A liquid biopsy, a good liquid biopsy is what we would do. So can this help us choose a little better? Because again, yes, please.
So on that liquid biopsy for ESR1, now when would you do it? And would you keep doing it?
We are going to come to that.
Okay.
We're going to come to that. Pre-lunch, we're going to come to that. So we said ESR1, and this is again subset analysis of the EMERALD. You can see that the number of patients in each of these subgroups is very small, but it also probably helps you to super select some patients. It shows here that if you've gone on a CDK4/6 for a period of more than a year or so, you seem to be getting much better benefits. I entirely agree that you've got 8 patients on one side, but does this give us a better feel of, you've been longer on the CDK4/6, you might benefit better on the elacestrant? Would you take this data into consideration?
Yeah, some data is there, but it might be other way around, that these patients are already having a good biology. That is why they
Okay,
did
so
well.
they're having good biology, so it's okay to put them on. So it just tells you, when they progress and you did a liquid biopsy, ESR1 mutant, they've been on a CDK4/6 for a longer period, that is probably a patient who's likely to benefit more from a oral SERD. The next question that also keeps coming up is, an oral SERD, is it better compared to a fulvestrant? Dr. Rugo, I want you to tell us the biological basis of how an oral SERD becomes better compared to fulvestrant. Why is it that it works better in some ESR1 mutations compared to fulvestrant? Do we really know that? Because at least the data from all of these studies clearly does not talk about it, nor does it show us. So your thoughts on that?
I think it's obviously a complicated area, and these drugs work by a variety of different mechanisms. So rather than just downregulating the receptor, they also degrade the receptor. And so there may be some ability to overcome the resistance that's afforded by ESR1 mutations. But the point you made about different ESR1 mutations and then people have multiple mutations is very good because it's poorly understood and poorly studied. Like there's not a lot of data out there. There's one ESR1 mutation that's been associated with resistance to fulvestrant, and again, because it prevents the downregulation of the receptor by fulvestrant, but you can overcome that with the oral agents. I think what's going to be really fascinating is seeing these new drugs, the PROTAC inhibitor and the CIRCAs and the et cetera, where you see a combined effect, and they may work even in patients who don't have ESR1 mutations better.
Okay, so we, at least from the data, from subset analysis of all of these data, we know that the oral SERD seems to be better than fulvestrant. So if you've got an ESR1 mutant, you get onto an oral SERD. If you don't, then fulvestrant might still be a good choice, so doing it becomes relevant. Changing from one CDK4/6 to another, the maintain study. Okay, another very important study, I suppose. Avinash, is there a set of patients in your practice that you would want to do this? Let's say AI palbociclib, change them to fulvestrant and change palbociclib to ribociclib. Is that something that you would do?
So after the launch of generic palbociclib, most of the patients are actually, I'm able to give only palbociclib plus AI in the first line.
Okay.
So definitely if they are progressing, since some data is there regarding changing and it is helping in improving PFS, I would change both.
So which patients are they?
Because
Because now you've got so many options. You have fulvestrant, everolimus, fulvestrant, ablasib, fulvestrant, capivasertib, or LSS plus whatever that is, and then fulvestrant plus
so the patients who are not having any PIK3CA or AKT or PTEN.
Okay, PIK3CA, AKT, PTEN, which you would have done a diagnosis. Excellent. So that's one. Does this forest plot help you? So I have put arrows on some point estimates. One is very interesting, that the only p-value for heterogeneity that is significant is the one for duration of previous CDK4/6, which says if it's less than 12 months, then those patients benefit. So is there some, that's actually counterintuitive to what you would think, because if somebody did well on your first line, you would think changing it and holding it for some more time would help. But it's actually counterintuitive. Again, Dr. Ruga, you are the one for all these questions.
My take on that was, one, these are tiny numbers.
Okay.
But two, probably they came off drug before they had true progression. And so that's where you're
But
really,
wasn't the inclusion criteria clear that they had to have progression
no,
before
because
they
you
were
could have
taken?
had treatment in between. They
Okay.
didn't, this was all by provider determination. And, we know that people go off therapy because of reasons that, maybe their marker went up, and they didn't really have progression. And, I think that's quite fascinating to think about whether or not one CDK would work after another. This is certainly encouraging, but it's still very early data. I think we do it sometimes in people who don't have mutations, but we need to wait for the post-Monarch show.
Biswajit, here again, ESR1 mutation seems to be very relevant, right? Patients who, Dr. Chia nicely showed you that data, so I'm not showing you that. Interestingly, it's behind this forest plot, but it clearly shows that if you've got an ESR1 mutation, you also have some co-mutations which tell you that the CDK4/6 is not going to work. So again, ESR mutation is important.
So,
please make your point and then you can answer the question. Yes, please. Yes.
I think as per the last discussion we had also, that the ESR1 mutation, the resistance pattern might be different than the CDK.
Correct.
So there is an option also of continuing just the CDK and just changing the AI to fulvestrant.
Okay.
So,
but the
whether
trial
that's an
actually
option or
did.
not.
So this trial
correct.
actually didn't do that,
In
right?
that
so
study we did not show that.
That's a good thought. What about ESR1 again here? Would you use the ESR1 mutation to make this decision also?
So, here you have, as per the
Yes,
mark, you
so
have
you
put
think
the
so?
numbers.
Because there's some biological basis for that, unlike the previous one, which Dr. Rugo rightly pointed out was small numbers, so we shouldn't overinterpret that. Yes, it seems to be that if you have an ESR1 mutant, you also have FGFR and CDKN2A, which are amplified or altered, which make these tumors resistant to CDK4/6. So ESR1 might actually be a surrogate for certain other mutations that might be there, which make these tumors resistant.
Sometimes,
so you may want to look at a different. Yes, Biswa?
Sometimes we have patients with very mild radiological progression.
Okay.
Let's say one bone becomes two or something.
Okay.
I have a couple of one
Right,
patient or two
that's a
patients
good
whom where you
point.
just change.
In clinical practice, we would do
Yes,
that
sir, but we
small
don't test that,
progression.
so we don't.
You're not too sure what's happening. That's, in my opinion, the best candidate for something like this, because you can quickly do an evaluation in 8-12 weeks and then decide what is. Yes, Dr. Rugo.
I would be cautious about saying that ESR1 mutations
Okay.
are a surrogate marker for CDK4/6 resistance, because
The other mutations which potent. Yes,
yeah,
in a way, yeah.
often
you're right.
people have co-mutations which correlate
Yes,
better with that,
yes.
but I think ESR1 per se
Is not.
Is not.
Agreed. Because we have data from the first line to clearly say that it's only prognostic, it's not predictive of the lack of benefit of a CDK4/6 inhibitor. That's an important point. Okay, so that brings us to a very important part of this, the PADA-1 study. Okay, so anybody here is ready for PADA-1, dynamic ESR1 monitoring? No. Lovely, no.
It's
So,
fascinating, and we need to wait for Serena
it's
6.
fascinating, and
But
we need
I
to
think
wait.
we should check, I'm not sure what the question was, but or what we do, but we know ESR1 mutations are acquired under the pressure of treatment, and then they come and go, unlike PIK3CA, which is conserved. So you have to check again, and blood is the way to check.
Yes.
In order to know if somebody has the mutation.
Okay, so for me, the most important, interesting part of what is there in the study is, one is that patients don't catch up. But for me, this is more interesting, Dr. Rugo. I want you to, help me decipher this. The PFS on second-line treatment is 16 months and 8.2 months. So how did I get this? I just subtracted the PFS1 from the PFS2. Okay? That's the only thing I could do. Because this is very surprising. How can you get a PFS of 16 months in the second-line treatment, which is much higher than any drug combination that we ever have in this disease? So is there something that I'm missing, or all of us are missing, or
No,
missing
it's an
data?
exploratory trial. It has about 170 patients, and the number of patients fall off a lot. If you look out to where you're saying it's 29 months for PFS2, there's a total of 26 patients there. So I think that you have to figure that this is data which is suggestive and interesting, but
Yes.
it's not a number to take home.
Okay, not a number to take home. So we're saying that anything that's a little intuitive, counterintuitive is because of the numbers.
Even if you
But I
look
agree.
at,
I
if
agree.
you
I'm
look at just 18 months, you still only have about 70 patients. This is really small.
Because this is what intrigues me about this whole study. The fact that you get a PFS2 that's better than PFS1, I agree with the numbers, but it's a lesson learned both ways. One is that we should not be over-interpreting. At the same time, we should not be ignoring. For me, the second is very important because it tells us a lot about trials and the way it's conducted and what patients have after and so on and so forth. Excellent. So our last part. ER positive, HER2 negative, second line. This is capivasertib. Okay, the trial reaching its primary endpoint. Dr. Chia went through this study again, and he clearly told us why the FDA approval is only for pathway-altered patients, not for all comers, right? Because there were about 15-20% of patients in whom we didn't know whether the pathway was altered or not because the samples were bad, inadequate, whatever it is. But nevertheless, good benefit. So I think the question is this. Anyone wants to take, who are these two guys? Lovely. Post World Cup, I believe they visited Kerala, right? So, with their chai. Okay, lovely. So should it be capivasertib or should it be alpelisib? Anybody, Dr. Bhavna or Rona, one of you can take that. I've just put the data that's available, the comparative data that I could get on the screen, but by no means is this the best way to do things. So.
Okay, so main concern while using alpelisib is the toxicity.
Toxicity.
Mainly hyperglycemia, because I
Okay.
think 1/3 of Indian population is diabetic.
Right.
Now, if you see the new drug which is there in the trial itself, the patients who had high blood sugar, they were already excluded. So that is also one more thing which we need to pay attention to. And apart from that, we all have used alpelisib, but not very happy managing to toxicity.
Absolutely right.
But the newer drug seems to be maybe better
The
tolerated.
drug seems to be better tolerated. Most of the time, we kind of say it's okay to use capecitabine rather than everolimus or alpelisib. Dr.
Yes.
Rugo, your experience with capivasertib and alpelisib, which do you think is easier to manage? Because that seems to be the deciding issue here, apart from cost.
Yeah, I mean, we allowed patients up to a hemoglobin A1C of 7.9%, so that was much higher, and you could have had an abnormal glucose at unlike the Inava 120 trial, which didn't allow any of those patients, and no one on Inava 120 had an abnormal hemoglobin A1C, so it's important to keep in mind there were no pre-diabetics by the definition in Inava 120. But, you know, Capi, you gave it on 4 days on, 3 days off, so management of the rash is easier, the diarrhea, they might have 1 day, you know, you can manage it pretty well. So in my experience, it's a much easier drug to manage, and they don't have that, you know, you finally get somebody through the alpelisib, and they get through it, and they're staying on it, and then their weight starts going down, they're just losing weight and feeling miserable, and we haven't seen that with Capi much either.
And the next scan is progression, right?
Yeah.
So
Well, no,
by the time
actually,
they settle down-
they can lose weight for a long time on the drug
No,
due
I
to a
agree.
metabolic
Whatever
effect.
little that we know
So,
of
yeah.
alpelisib,
But
that's
Inavo,
the way.
fascinating drug, but not
Correct.
tested
So
in
just let me
diabetics.
tell tell the audience what this is all about, and then you can 30-second summary of this. So this is while we are discussing ESR1 mutant, PIK3CA later, and then do the drug, and here and there PIK3CA is moving to the first line. It seems to be successful because that's the press release that when you have 3 drugs is better than 2 drugs if your PIK3CA is mutant. So maybe you can do a Sonia again.
Well, so
Right?
this,
No?
this
Late to the
trial,
party again.
it actually is very cool.
Okay.
So first of all, the press release came out on Tuesday, and because San Antonio is not mired in the same structure as ASCO and ESMO, Virginia Kaklamani called me up and said, do you think that they would be willing to present the data? I'm like, I don't know, it's 3 days from now. So we actually talked with Roche Genentech, and through a lot of discussions that were 24 hours, they agreed to present their data 3 days after a press release.
Okay.
That's so important for everybody to get that information.
didn't
And
know
then
that. Okay.
I was the discussant,
Oh, lovely.
which meant I didn't sleep for 2 days. But the cool thing about this study is there was preclinical data in several different labs, and mostly out of Boston, that showed that if you give the doublet of a CDK4/6 inhibitor and a drug that blocks PIK3CA versus the CDK4/6 inhibitor, that you have an improvement in patients who have in tumors that have PIK3CA mutations, and when you added endocrine therapy is even better. But we couldn't do it before because the drugs were too toxic. So this drug, a third of the patients had primary endocrine resistance, so they progressed within 2 years of starting their adjuvant endocrine therapy, and the rest progressed either on their endocrine therapy or within 12 months. And still, we saw this dramatic curves. You don't have the curves
Yes, I
here,
don't.
but you don't see an early drop off.
Okay.
So you're able to overcome that initial resistance, and the drug was very well tolerated, but they didn't have any diabetics.
So that's the key. Okay, so 5 consensus statements. Who's going to read out the question? Okay, let me do the honors of reading out the question from my own discussion. So I've made it simple: yes, no, or don't know. Okay, so those are the choices. So you will choose. I think your this thing is there in your chairs. Okay, ovarian function suppression for all premenopausal women with high-risk tumors who continue to remain so after chemotherapy. Oh, you can't answer, right? So you already had a chance to answer. Wow, lovely. Super. Excellent, not bad. We've been able to convince some people. Okay, Natalie, ready for prime time. You can start answering, I suppose. I think here also it'll be the other skyscraper. See, it's 10 seconds and you're wasting time. Whoa! I think I need to do this panel discussion again after lunch. Okay? Right, broad panel NGS for all patients with ER positive, HER2 negative MBC, because you want ESR1, you want PIK3CA, you want AKT, you want P10, and then BRCA. So that's the reason for this question. So you know the answer now, huh? Okay. Expected, that's all right, because it depends upon so many other factors, including access to drugs. If you don't have access to drugs, there's no point in doing all of these things. Makes a lot of sense. Okay, next one. Can delay use of CDK4/6 to second line? Dear Sonia. Okay, no Sonia, right. So some people still want Sonia. Okay, last and final, dynamic ESR1 mutation monitoring. Okay, the PADA, or, keep doing it at every progression and then try to choose some of those drugs. Okay, every 2 months ESR1 monitoring. Oh, lovely. See, something. So I think the reason for all this is because people are hypoglycemic. It's not because they think what is happening. Lovely. Excellent. So we'll stop there. Otherwise, they'll throw me out. Thank you so much. Sorry, other panelists, because Dr. Rugo was here. I had to ask all the questions that I had doubts into her. So apologies if you felt that I didn't, ask you many other questions. But I think that's okay as long as we all learn. Thank you so much.